Welcome everybody to our third community conversation. Today the topic is going to be telehealth. I'm so glad you could all join us. I am going to just make some brief remarks at the beginning. Then we're going to have a long and robust conversation with our panelists. And I'm going to leave some time for questions at the end. If you do have a question at any time during the panel discussion, you can click on the Q&A button, which should be located on your Zoom control panel. You can send questions at any time during the panel and we will begin answering them at the end. Before introducing the panelists, I wanted to start by setting the stage for why Children's Law Center cares about this topic and is having this community conversation. As you know, we have a vision for all children in DC, that they have stable families, good health, and a quality education. And we work towards that vision by providing individualized legal assistance to more than 5,000 children and families every year. Taking the breadth and depth of that experience, we turned it into citywide solutions, working with the mayor, the DC Council, government agencies, and allies. Our almost 25 years of experience has shown us that family, health, and education are inextricably linked, that without a solid foundation of all three, it's really only the exceptional few children who can thrive. Even before the pandemic, our children faced incredible barriers to being healthy. Sometimes because schools weren't providing the tools for a child with a disability to learn, sometimes because a child was experiencing trauma of abuse and neglect at home, sometimes other times because of unhealthy housing conditions. We look for any tool that can make healthcare more accessible to our children and families, and telehealth has been an important one. So with that explanation as to why we think this is important, I want to introduce our panelists. Each of them has a long and successful career and has won many awards. So I'm gonna have to stick to just a few highlights about each one of them. First, Melisa Byrd is the Senior Deputy Director and the Medicaid Director at DC's Department of Healthcare Finance. Throughout her nearly 20-year career in healthcare, she's worked at the local, state, and national levels in both the public and private sectors. Second, Karen Dale runs AmeriHealth Caritas DC, which is the largest Medicaid managed care organization in the city. A nurse by training, Karen has worked inside government as well as in the private sector and has won too many awards to mention for her visionary leadership. And one example of Karen's visionary leadership is something I'm very proud of, which is a first in the nation contract between Children's Law Center and AmeriHealth to ameliorate housing conditions which impact children with asthma. Children's Law Center did a financial analysis of the amount of healthcare savings when we help a child with asthma eliminate the mold and the rodent infestations in their homes, and learned that on average we were saving over $10,000 a year for AmeriHealth and other insurers. And Karen saw the value of that and decided to share the savings with us so that we could do more of that work. So we're really excited to have you here with us, Karen. And last but not least is Sharra Greer, who's our policy director at Children's Law Center. It's a role she's held for more than a decade. In that role, she has successfully advocated for dozens and dozens of citywide reforms, including on children's mental health, things that have led to thousands more children receiving services in school and in the community. One key characteristic of all three panelists is their willingness to partner together and across sectors, which is something I am sure they are going to talk about as we begin to talk about telehealth. So let me start with a very straightforward and basic question. And Melisa, if maybe you could answer this. Can you start by telling us what is telehealth?
Sure, and thank you so much, Judith and the Children's Law Center for hosting today and having us here for this discussion on telehealth and telemedicine. So really just on a high level view, telehealth refers to a broader scope of remote healthcare services than, say, telemedicine. So telehealth can refer to remote non-clinical services such as provider training, administrative meetings, continuing medical education, and public health functions. So you're going to hear us talk about both telehealth and telemedicine. Telemedicine refers specifically to remote clinical services. A couple other definitions you might hear throughout our discussion today is the originating site, and that is where the patient is during a telemedicine encounter or visit, and then the distant site, which is where the rendering provider is located during that same encounter. And so that's really the highest level overview. You can always find more details and exact definitions of telehealth and telemedicine if you go back to the Telehealth Reimbursement Act of 2013, and then specific to Medicaid through our rulemaking, and we have provider guidance on telemedicine on our website as well.
So Karen, what does that translate to for you? When I listen to that, I think of something like this Zoom. And is that what telehealth is, or do you have a broader array of media to draw on?
Sure. So I will stick with more of the telemedicine components. For our enrollees, we have taken the approach that we want to have a rich array of tools and modalities that better fit into their lives. Think about it. The person who has commercial insurance has an array of benefits that support their health and well-being. And if we took a health equity lens, I would offer that our enrollees that we serve need that higher stool to step on, right? So that they are having that equitable chance to be healthy. So we've leaned in, and prior to the pandemic, we were offering Tele Monitoring services, which allows for our enrollees to, for example, the person that might be diagnosed with diabetes, to have a diabetes monitor that can transmit directly to their practitioners on a more routine basis, their hemoglobin A1C or their blood readings, or their, we might, for the person with hypertension, their blood pressure readings. And that more just-in-time information being provided to their practitioner does two things. It allows for more immediate tracking and interaction, which is always good. It also responds to something that humans do very well, right? So when you're trying to lose weight, if you get on the scale at least 2 or 3 times a week, it heightens your awareness. So the whole arena of remote patient monitoring is really helpful in the sphere of telemedicine, and that can extend to other disease states as well, such as congestive heart failure, etc. The other component, yes.
Oh, keep going.
Other components may be a lighter touch, like text messaging, right? To give people reminders about medication, or give them reminders about appointments, etc. So that fits in there because we're still focused on something regarding health content. Making sure that we make things more convenient, such as you might go to the emergency room when you don't need to because you didn't really have another option. And so having a vendor that provides a practitioner at your fingertips on your phone is a great way to get that immediate feedback about whether you need to go to the emergency room, or possibly based on a smart algorithm of questions that the enrollee is asked, they may be able to diagnose, right, for something fairly simple like allergic rhinitis, where the person has a runny nose, they don't have a fever, but they're not sure, should I go to the emergency room? They could prescribe something that's needed, or give them that specificity of clinical direction that avoids an emergency room visit. So there's that full range. There's also specifically to behavioral health, lots of peer support type platforms that are out there, and we are in conversations to try to understand more about how those can be used. There's one organization with whom we've had really good conversation, as we are more concerned that for our youth, that missing the in-person peer support that they often get, that can be very stabilizing and supporting, that during this time that they've been at home for extended periods of time and maybe not interacting as much with their peers, that having a platform that's designed to give a bit of coaching and support and more connectedness can also be a great support and adjunct to what they need to be healthy and well.
That's great. And it helps me to think beyond the more traditional, am I going to be on the phone with a doctor or looking at a doctor through a screen? And with that now sort of new expanded understanding of what telehealth and telemedicine is, I want to turn to our audience and ask you whether you've ever used telehealth. You're going to see a poll on your screen. You should see it right now. Your answer would be anonymous, and we'd love to have you take just a moment to respond. The question is, which of the following best represents your experience? 1, I had already used telehealth before the pandemic. 2, I first used telehealth during or because of the pandemic. And 3, I've never used telehealth. So, so we know where you all are as we begin to think about that. And perhaps we can just see the results at the same time or before we move on to a question. Magically, it comes up. So we have a real mix. Almost half of the audience has never used telehealth, but 20% had used it beforehand, and a good third have first used telehealth during the pandemic. And we're going to come back to that range of uses in a minute. You can probably take down the poll. So let's move back to pre-pandemic days, the good old days. I know that for each of the 3 of you, telehealth was already on your radar. And so I want to start there and ask, why were you already thinking about telehealth and what were you doing? And I'm actually going to start with Sharra, who I know was thinking about telehealth for our clients, but can you tell people why?
Yes, I mean, for a lot of our client community, we're thinking about telehealth because we wanted to make accessing healthcare easier for them. And I think a lot of people, when I first started raising this, were saying, well, DC is a small city. It's not a big deal to get cross town. Why is this such a priority? But for many people, anybody who's tried to drive cross town, really at any time we had normal rush hours, getting cross town is actually a pretty big deal. And if you're trying to do that on public transportation and you have 1 or 2 or 3 children that you're also needing to take care of while you're trying to go to an appointment, that starts to be really daunting. And then for a lot of our clients, it made it really difficult for them to keep their appointments and keep their children making necessary health appointments. So making it as convenient as possible for them so they could access their healthcare was a real priority for us. And that's why we're trying to explore other ways like telemedicine to make it easier for them to connect to their healthcare providers.
And how about you, Melissa or Karen? What were you thinking
Sure.
before the pandemic?
Well, I think very much in line with Sharra, you know, our priorities right now are to really look at ensuring we are providing or enabling whole person care. And part of that is certainly focusing on the patient. So it's an access issue. Let's meet the patient where they are when they need services. So it really is, I think, through that lens that we've been looking at it in terms of from the Medicaid perspective. And, you know, one of our core components is access. So whatever we can do to enable access more regularly and easier for the folks that we serve, that's what we want to do. And telemedicine is certainly, we're seeing right now, certainly helping us do that.
I agree with my co-panelists. I will add one other thing, which is around behavioral health. Somewhere around, I think 8 years ago, we started, we tested a behavioral health telemedicine solution. And that was in part to help address the stigma that is still associated with behavioral health. And so if I don't need to go to that place where everyone knows I'm going to see a behavioral health practitioner, and I can access it on a phone or through my, to my phone with the video, etc., that possibly that would give people, again, another access point and modality in terms of getting the care they need. It was really interesting to me that our first enrollee who used it was a mom with postpartum depression, right? And so when you look at it through that context of also just the just-in-time, the decreasing stigma, and having people feel a bit more comfortable, right, than being in person, which can feel a little daunting and may not feel like you are at that equal place with the practitioner. It was interesting to see how she responded in a much more calm way, less fear, and she didn't have to worry about the childcare or the driving.
Makes perfect sense. So that's the stage, that's where we were before March. Let's jump ahead to March and the beginning of the pandemic. And I know that telehealth has become more available and is being used much more than it was before. What made it possible to pivot in March? What was the landscape that had been created, Melisa, that allowed you to make the important changes? And what were some of those changes?
Sure. So kind of to jump back to the pre real quick, and I mentioned earlier the Telehealth Reimbursement Act of 2013. So fortunately in the district, as a Medicaid program, we already had the authority to reimburse Medicaid services via telehealth. And we've really created a framework that uses telemedicine as a modality of care that can be reasonably delivered at the standard of care. So where that's important and where you may see different experiences across the states is that instead of creating a brand new service, something completely distinct for telemedicine, if you have any kind of regular visit, if you will, you can add them what we call a billing modifier to it and conduct it through telemedicine instead. So we didn't have to create a whole new set of codes or services or reimbursement streams. And so that was really foundational. It allowed people to pivot, I think, fairly quickly. And for those who are doing the billing to get the revenues back in, it's a simple two-letter modifier on the claim. So it's a fairly easy lift in terms of an administrative change. A couple things that were really that helped us pivot even more quickly was that we had the infrastructure in terms of the legislation and the regulatory framework, and then we were able to quickly make some changes to enhance and make telemedicine more available to individuals. The first one was changing the originating site. So prior to the public health epidemic, individuals could not be in their home to receive telemedicine. So we made that change, I think no later than mid-March. And so that originating site, so I can sit in my home, I can connect with my provider, and can have keep continuity of care or ensure I'm getting the care at the time that I need it. The other significant change that has come along with the public health emergency is to use audio-only telemedicine as well. So typically, and we're precluded through the current legislation, you cannot do audio-only telemedicine. And so that really has made a change, and we'll talk a little bit more about later, but we've certainly seen a big impact on the behavioral health services side with that change and allowing that continuity of care. And then finally, so we had local flexibilities that occurred, but there were also, one in particular key flexibility from the federal side is the flexibility to use non-HIPAA compliant technology. So many of us have iPhones, and iPhone is not a HIPAA compliant technology because they don't have a business agreement. But right now, the Office of Civil Rights in the Federal Health and Human Services Department has allowed that flexibility. So a combination of our infrastructure, some quick turnaround or flexibilities on the local side, plus those on the federal side, have really allowed us to pivot. And the experience that we've seen in Medicaid is a little bit different than the poll that we just saw, where in 2019, the total number of telemedicine claims that we saw were about 13,000. And then since March 2020, so in the just past 2 or 3 months, we've had over 232,000 claims. So we went from, having less than 1% of beneficiaries at the beginning of the year utilizing telemedicine to almost 18% since the pandemic occurred are utilizing telemedicine services.
That's amazing. Sharra, what was our experience with our clients and their families being able to access during the pandemic?
I mean, the fact that DC was able to pivot so quickly was vital, and it was just, I can't overstate the importance to our client community, because so many people, one, did not want to go into a building. They didn't want to go into a building once a pandemic hit. A lot of our child clients are medically fragile. We also have caregivers who have health issues. And it was pretty scary for a lot of people to think about going into a healthcare setting and being around lots of other people. Also, schools were gone. So in terms of the ability to, not have all your children with you all the time, also made it more complicated for people to try and even make appointments, even if they wanted to. And then transportation became less available. So all those things made it even more difficult for people to access traditional visits. So being able to access healthcare via telemedicine made it possible for many of our clients to even continue their healthcare. And in particular for our clients who rely on behavioral health care, which is a really important service for a lot of our clients, it was essential. because that transition was easy and quick, and often those were regular appointments, and they were able almost immediately to move from in-person to virtual. And being able to have the telephone option made it possible too for a lot of our clients who don't have a lot of devices in the home. It was just really sort of that lifeline. And we worked really hard too, because a lot of people at first didn't realize they could make that shift. So it took a little bit of publicizing that, yes, providers had made that shift. You could change your appointments to this new system. And, you know, a lot of the different programs did outreach, like, for example, the school-based mental health programs, even when schools stopped meeting in person, continued. And so getting those providers to be able to reach out to the students and to the school community saying, we're still here and you can still utilize our services, and you can do that via your phone, via your tablet, was just really important in providing support to folks during, you know, an incredibly stressful time for them.
So share how we help to get the information out to our clients about which behavioral health providers were available.
Well, the first thing we did was we wanted to make sure everyone knew. So our staff actually called all the behavioral health providers in the city and asked them, are you able to make this shift? What kind of telehealth are you providing? Are you taking new patients? What kind of new patients are you taking? And we put that out there, and then we sent it out to the larger community. So both our clients could access those services, but also the larger community could access those services, and make sure the word got out that that was available, so people weren't feeling like they were left isolated without help.
Great. Karen, is there anything you want to add to this piece of the conversation? What made it possible to pivot and how you pivoted?
Yeah, we've seen a very similar increase prior to COVID. We had about 300 telehealth visits, and in June we had over 22,000. So it certainly tells us something about how useful this modality could be, utilized to help, especially a population that has a scarcity of time, transportation, financial, and childcare issues. The thing that I would add is how it also helps a provider practice, right? In terms of how they schedule. Providers have often observed that with our Medicaid population, sometimes the no-show rate is higher. And so as we similarly outreach to providers to ask them about telemedicine, what they told us was that the no-show rate was almost zero. So it's not that telemedicine replaces everything else. However, taking the benefits that we've seen both to providers and the population served, as we co-imagine the future of health, we should think about how do those components play out to improve health for district residents.
That's great.
And
oh, go ahead.
Well, Judith, if you might, I would just also add that, you know, in some respects specific to the provider, it does give the provider some stability in being able to maintain services to individuals. And, you know, we are kind of curious to see how this will work going forward as providers change how they have their waiting rooms and can only allow so many individuals in at a time. And will this help providers, you know, maintain the kind of level of utilization they're used to if they can do some in-person, some telehealth or telemedicine visits. So, you know, it's just as important to make sure that we have the provider and the health delivery system intact as best we can post-pandemic. And I think telemedicine is showing us that that is a way to help us provide some of that stability to providers.
That's great. Before we talk about how it's working and where we can go in the future, let's take a moment to talk about what the barriers are. So I know that there are still some significant barriers to telehealth during the pandemic, and maybe folks can share what those are and your thoughts about them. Who wants to go first?
So I would say still doing more education with our enrollees so that they understand or not confused, publicizing and understanding which providers are offering it, as you all had mentioned, because sometimes someone may have been doing it and then they're not, or the practitioner in the practice who was doing it is not. And so we just have to smooth out some of the connecting and detail components. The other piece is there are still parts of our city where there is less broadband access. I seem to recall at some point the city has considered budgeting around Wi-Fi in more spaces. So things like that where we close the digital divide a bit will be important. I was heartened that with the free federal phones that they did increase or remove the restriction on minutes and data. So again, thinking about those kinds of things that for those we serve may become barriers to access, even though something is available.
Sharra, what are we seeing with our clients and other barriers? Yeah.
As some of the things Karen is raising, it dovetails well to one of the barriers we're seeing, which is not all of our clients have regular access to the internet. You know, a lot of them are using cellular services, which, you know, they're not necessarily on unlimited minutes. So when they run out of their minutes, they don't have access to the internet anymore. Also, we have households that are sharing, you know, 5 people sharing one device, which can make it difficult if people have competing needs for work, school, and a telemedicine visit. So that can be really complicated for our clients. We also have some, you know, especially in the behavioral health sphere, kids are not always comfortable being overheard in a house when they're talking to their provider and their clinician. And when everyone's at home together, that can be really difficult for them to have the necessary privacy to have those conversations. And so that's also been a bit tricky in terms of our clients being able to navigate accessing services through telehealth. And then also what you were saying as well, which is just making sure our clients are aware of it. I mean, fortunately, we can tell our clients, but our clients are only a small slice of the larger community that we want to be aware of these services being available.
I would just echo those, everything that Karen and Sharra said. I think, you know, up to this point, for us, it was really looking at how do we encourage providers to engage in telehealth and telemedicine more frequently. And that seemed to change overnight, which is really fantastic. But these other issues that we now see with the digital divide or having the data plans accessible, or having devices that everyone can access, I think that has been a bit, the extent has been a little bit of a surprise to us, but I think is now showing us what's next to have to look at and everything.
So we've gotten a lot of folks using telehealth or telemedicine. Is it working? Do we know whether it's succeeding in getting the necessary health outcomes for your consumers?
That's a difficult area for us to figure out now. I think anecdotally, we hear that individuals are satisfied with their visits. They're happy to be able to utilize telemedicine, but we're, you know, from the Medicaid world, everything is based on claims, or most of our information is based on claims. And we usually have at least a 3 to 6 month, you know, lag, if you will, before we have our claims data. So it's very difficult for us to see at this point any kind of trends in terms of, you know, changes in health status and whatnot. Karen may have a better sense, since she's a little bit closer to the ground, if you will, than I am, but I do think that's what we'll be looking at next, right? Is the standard of care being maintained? Is, you know, consumer satisfaction being maintained or improved? And then on the health, the actual health quality, how do we measure, and what will we see from there? So I think it's a little early to tell from true data quality metrics, but something that we'll certainly be looking at.
Sure. So qualitatively, I agree. We've heard very positive feedback from our enrollees and our providers about the experience. When we think about the data, we are limited by the fact that the modifier just tells us it's a telemedicine visit. It doesn't tell us what type of telemedicine visit. So telephonic only versus telephonic with video. And that might help us to understand some things better. It's further complicated in that some COVID factors make it a little messier. So think about the fact that people have been very concerned about going to the emergency room. Yeah. So we don't see as many low acuity emergency room visits. And we've seen this increase in telemedicine visits. So separating that out to understand which thing, in fact, you know, influenced which would be challenging. What we are going to try to do, though, is to still look at the data, especially for people with chronic diseases, and see how many telehealth visits they had and what happened as a result. I always say that this is one of those things where we want to balance the picture, right? So thinking about children for a moment, we did see a fair amount of visits for children. However, for the annual physical, right, they need more than what can really be done well via a telemedicine visit, as well as we have a large concern about children getting their appropriate vaccines. And that can't be done via telemedicine. And that can put them at risk and other children at risk, right, if we don't figure that piece out too. So I always want to say, yes, it's a great story. However, we have to balance it with, especially when we're talking about children, some of the additional things that are important to their health.
Maybe we should find out from our audience, because a number of you have actually already used telemedicine. So let's do another poll and ask the question, how would you describe your experience with telehealth? Was it positive, neutral, negative, or obviously if you haven't used it, you have to say not applicable? And see whether the experience that Karen and Melisa are hearing is the same as our audiences. And why don't we, while folks are doing that, let's go on and talk about the future. So we've talked about sort of how fast we've been able to pivot and how much telehealth is being used. There is going to be a future where we are not all working remotely and not completely constrained by the pandemic. So why don't we talk about what lessons we've learned and what you see as the future? Karen, where do you see this going? How will AmeriHealth be using telemedicine and telehealth? I think maybe we can broaden it.
Yes. I believe we should continue to use as many modalities as our enrollees find effective and useful, and our providers can do in a way that is convenient for our enrollees and also produces better outcomes. So I would love for us to continue with some telephonic. I don't want it to be that telephonic only becomes the predominant method. My concern there is there's still something very useful about relationships between a provider and their patient that is established via the human-to-human contact, not necessarily through phone. And in the population we serve, sometimes part of what creates the barrier to that relationship is that level of engagement that needs to occur, right? So if you and I have a really positive interaction that engenders trust, I am more likely to fully disclose some of those things that are occurring in my life that might be health harming, sometimes called social determinants of health, because I don't fear that I'm going to be judged. So we have enough rapport and trust that I'm going to share those things. And if I don't know this for sure, but if we start and it's mostly via telemedicine and I don't know you, we don't already have that established trust, one of my questions is whether that relationship gets as well established as possible to have that comfortable information flow and connection that helps the whole person, you know, as Melisa mentioned. So in the future, I want to see the appropriate balance of use of telemedicine and telehealth, right? So the things that are not necessarily purely clinical that help us to connect people to resources and supports. I want to also see more closed loop, right, in the activity. So closed loop might look like if you go to a service that's not on the medicine side, it's more on the social service side. Do we know that the person who we referred to the service, did we know that they went? And do we know whether they were satisfied? Those are all great markers for how we improve our performance to support people to be healthy. And I'd like to see that same kind of closed loop on the side of clinical services, right? So that we, think about it. Every time you go to a restaurant, you can rate them, and people are concerned about those ratings. So the more we not just utilize it in a siloed fashion, however, we think about how all these components can be better integrated, it helps us to create a better delivery system. And lastly, I would say, to the extent that these components of telehealth and telemedicine connect to the wonderful investment we've made as a jurisdiction with our health information exchange, that really will take us to a whole nother level of performance as a health delivery system.
So is there learning about how to build trust remotely? I think anyone in the audience who's a parent and thinking about their child going to school and getting a new teacher this year has already begun to grapple with, oh my God, how are we going to build trust so that we can learn? And is that a field of study? Are there techniques that are being developed? Do you know?
Yeah, that's a great question. Someone should be working on that because I do have that concern. I have to see what's out there.
Melissa?
I don't know specific on the trust building component and what there is. From the Medicaid perspective, our focus is still on kind of building out the infrastructure. We did recently apply for and receive federal funding to support telehealth efforts in the district, specifically to purchase and loan laptops and tablets and data plans to providers with limited capabilities, and distribute HIPAA-compliant telehealth platform licenses to providers without a license. So this is provider-focused and not beneficiary-focused in this respect, but really trying to kind of further ensure that the providers across the district, particularly those who are serving Medicaid beneficiaries, have access to these services to enable telemedicine. And I think one of the things that we've seen, I agree with everything that Karen says, also is just, I think for me, one of the biggest lessons learned so far from the pandemic is having these set of tools and options at our disposal really has a tremendous benefit when we do need to pivot or change kind of our normal behavior. So, ensuring someone's continuity of care, if we have to, while maybe their preference is to be an in-person visit, but then something like this happens, or the safest thing for that individual is to be in their home, but still connect with their doctor. I think that has really kind of what I've taken most from this, of just making sure we have all these different options available to individuals so it best suits their needs.
So I have a question. When you mentioned some of the federal rules, and I know that when Karen and I were negotiating our contract to do the work on behalf of kids with asthma, that HIPAA, an organization like Children's Law Center becoming HIPAA compliant was a big lift, and we were able to do it, but I know that that was a barrier. So I used to say to our allies, and some are in the audience today who are federal level lobbyists and lawyers, let's amend HIPAA, and they would all start laughing. Like, that was impossible. Don't even mention it. And so with that understanding that that is a big lift, what are you hoping the federal government will do? That they can keep loosened, or what changes you see are necessary for us to move forward?
Well, I think, the federal government pivoted fairly quickly as well, I would say. That was complementary to our local efforts. I think one of the biggest indicators of the federal government's kind of stance on telehealth or telemedicine right now is they're making some of the changes to Medicare permanent. And while that doesn't specifically, impact Medicaid, Medicare is oftentimes the standard at which, things are allowed beyond Medicare services. So the fact that telehealth and telemedicine will remain part of Medicare is a big shift. And I think that will naturally steer, or I hope it will naturally steer the federal government to looking at what else do you need to do to ensure people have access. Of course, the Medicare arm falls under CMS and the Office of Civil Rights and HHS that has this particular HIPAA piece about the HIPAA compliant equipment are separate entities under the same house, or separate rooms in the same house. But I do think we're going to see a lot more over the next few months. Again, with the uncertainty with the pandemic, are we going to have another surge or something like that? I think it is bringing forward the the importance to try to make some of these decisions quickly, but thoughtfully. And I hope that will be a motivating factor as we go forward.
Great. Before we take questions, and I see that a number of questions have come in, Sharra or Karen, is there anything more you wanted to say on the future, the future of telehealth and telemedicine?
No, I hope that we adopt this idea of being extremely agile as it comes to all those components that are within our power to measure, evaluate, and launch, and not let time become, this very long process when people's lives can be improved by more rational and speedy decision making.
Yeah. And we didn't talk about the incredibly collaborative nature of the work that we've done together, but I do think I want to just comment and add in, sometimes we complain about DC government and is it moving fast enough? Is it getting things done? And this is one of those areas to be proud of our government. I think that we can feel really good about, Melissa's terrific, and the way in which we've all been working together and sharing information back and forth has been really extraordinary and a really positive moment for all of us to be proud of the way in which the collaboration has worked. And Melissa, your leadership on this has been really terrific. I have lots of questions that have come up, so why don't I jump in and start with them. And the first one is about inequities and gaps. And so we've talked a little bit, but not as focused. The question is, what are the inequities or gaps that have emerged in the use of telehealth? And what can be done to improve accessibility? So we've talked a little bit about the digital divide, and that has been a big gap. Are there any others that we should be talking about where you're seeing inequities because of race or economics or any other role?
So if I think about the disproportionate impact on health and well-being during the pandemic, think about the fact that, for example, we know in wards 6, 7, and 8, there's a higher prevalence of childhood asthma. We know there's a higher prevalence of certain chronic diseases, hypertension, heart disease, diabetes. And though some things can be offered through telemedicine, you have a population that's already heavily disease burdened, then I'm not sure that telemedicine necessarily gets us to a point of equity. It helps in the meantime. And so those types of disparities, inequities that result from the lived environment being under-resourced, some of the pressures and life circumstances, the higher rate of violence in the neighborhoods, the rate at which there are people unemployed pre-pandemic, overt racism, just all those things don't go away because we have a more accessible solution. And so again, back to when we think about the whole person in the context of their lives and their environments, we have a lot of work to do.
So this is a question, Melissa, that I think is probably aimed at you. And let me read it. Children's National has seen great success with a multidisciplinary virtual asthma home visiting pilot program that they've recently implemented. They envision the need to continue these virtual home visits beyond the pilot period, which is set to end in December 2020. From the healthcare finance perspective, what's the feasibility in getting Medicaid reimbursement to sustain virtual asthma home visits? And what steps can Children's take as an institution to pursue those? I think
Sure,
we're asking for some advice here.
No problem. And it's probably best if the interest is there, follow up with me afterwards and we can set up a meeting to certainly walk through how we do this. But to the extent that the virtual asthma home visiting pilot entails covered Medicaid services today that can be delivered at the state of care, then they should be reimbursable. It's always the details that can catch us up a little bit, which is why I would suggest having a follow-up. But again, the way we have set the framework for telemedicine for DC Medicaid is a modality of service. So if these are allowable covered services, then there should certainly be that flexibility to be able to reimburse them beyond the public health emergency. Again, virtual, it's also what's the definition of virtual. If it's the audio only, or if it's the HIPAA compliant, you will also have to deal with the federal level stuff. But I definitely think there's some opportunity there.
Great. Sorry, I'm trying to manage reading questions as we go. Karen, did you need anything to add to that, or did Melissa answer?
No, ma'am.
I got it. Are there any special considerations when the consumer is a child? So how do you handle telehealth or telemedicine in the context of children?
There's an appropriateness factor. I believe when we are looking at children under the age of 5, that there needs to be more attention paid to prep, especially with the parents, in terms of how to help manage the child, set up the most appropriate environment for the service to be delivered, which again, as Sharra mentioned, can be challenging in a household. I would say more time for the preparation and context setting and environment is important, because children of that age can sometimes be challenged with directions and follow through. And if they have a diagnosis that makes that more complicated, you just have to pay more time and attention to that. Otherwise, the experience for them can be more stressful, and that's certainly going in the opposite direction of what we hope to achieve through the visit. I would also say not every practitioner is set out to provide services via telemedicine. And so one of the things I hope comes from this is also providers taking time to do the appropriate training to help them about how to do some of these things. And in the situation I mentioned, I imagine a conversation may need to be had with us as a payer. Do we reimburse them for that additional time that might be needed for the support of the parent to prepare the environment, to know what to expect and how to manage that telemedicine appointment?
Sharra, I know Children's Law Center has been fighting very, very hard for school-based mental health programs to be started, and we've got them in lots of schools. I know you're still fighting today to make sure it's in this coming budget. Can you talk a little bit about how telehealth has connected to school-based mental health?
Absolutely. I mean, the providers in the school-based mental health program, if folks aren't familiar with it, this is the expansion program. DC is in year 2 of connecting every single school in the city to a community-based mental health organization that provides services in the school. And so every school has that ability. Right now we're about half the schools. We're hoping next year to expand out. And when the pandemic hit, almost immediately all of those providers were able to move to telemedicine. A couple immediately, because they were already set up for it. It took them a little bit. But that allowed those providers to continue to support the students who they've been seeing in the school, and not just individual students in clinical settings, but also groups of students who they were doing sort of broader support for, which was really important because it was so stressful for kids to not be in school anymore, to watch family members lose their jobs, lose their lives, and provide a forum for a lot of those kids to express that grief and the stress that they were going through. And that has continued, and a lot of those programs have even continued over the course of the summer to provide supports and services to students and families over the course of the summer. Which again, this is back to a point that Melissa made early on, which is we want to have services where kids are and they can connect to, and also that they trust. And so having a voice and a presence from school that comes to them has been really helpful and important for them. And it's something we're really hoping continues, as it looks like we're going to stay virtual for quite some time in the academic environment. And certainly it hasn't become less stressful for kids and families as we continue to be in this pandemic world.
Yeah, and it seems to me we spend so much time talking about the experience our children who have suffered a lot of trauma have, and building trust with somebody is a big piece of that. And so Karen, when you talked about the trust component of the practice, it feels like if we're going to center our work on the kids and families in our community who've experienced a lot of trauma, that we're going to really have to tackle that. And school-based mental health is obviously one of the really terrific solutions. I know that both Melisa and Karen, you've shared that you were surprised at how much behavioral health was being used. Telehealth, can you talk about, I don't know whether you have the numbers or just what is happening that way, the use of telehealth for behavioral health compared to other things?
Sure, I can say for us, so I mentioned earlier that since March 2020, we've had over 230,000 claims related to telemedicine. And of that, behavioral health claims account for 71% of, actually I have two different numbers. So total over 200,000 claims just for April and May. Behavioral health accounts for 71% of the telemedicine claims that we've seen. So clearly a significant portion. And you know what I don't know yet, but I am curious to see, and we'll be looking at the data, is how many are more continuity of care, folks, individuals who are already accessing these services, and how many are individuals newly accessing services, whether it be related to the pandemic or something else. So that will be some of the kind of deep dives that we'll start doing once we can with the data.
Yeah. I don't have the exact percentage. However, what Melisa has stated sounds right. And my guess is at least 50% of those persons are new. And here's what we're already seeing in terms of our care management services. The stress of pandemic-related repercussions has just been huge, right? So if you've lost your job, think about the things that we know are often our major life events. So you or someone you love has lost your job. In some of our household, both people lost their job, right? And then you have the additional stress of everyone being in the confined space together for long periods of time. I have lots of space, and on any given day, the fact that my son is gonna talk to me in the middle of a meeting, but I'm trying to concentrate, and he's trying really hard, like he sign languages to me beforehand, and then he just can't help it. He walks in anyway, right? Those pressures, day after day, we're into what, about month 5 of being, going through all of this. So for the person who then has already a lot of burdens, right? I'm living in a neighborhood where there's a higher degree of violence. If I need to get groceries, it is not just the easiest thing. I may not own a car. My bills are piling up. I'm one of the people on the list when the courts start processing evictions. That's probably going to happen. I mean, it is just so much more pressure on a daily basis. And then I've lost friends and family to the pandemic. We're finding that people who previously didn't have a diagnosis of something are certainly moving into having an adjustment disorder that's turning into a bit more anxiety, that's turning into major depression, and a whole host of things. And I may have waited longer to bring this up because I wasn't going for routine care in person, right? And so, and my usual supports, I'm not seeing them as much because we're all trying to social distance. So this compilation of factors has made it so that we're seeing more people seeking behavioral health visits. And so part of what our push has been, or the education component, is for people to go and get the care for themselves and their children more quickly. The other piece that we're seeing is that starting about 3 weeks ago, we are seeing a surge in behavioral health admissions and readmissions, right? So people may have been, concerned about going to get care. And so there's now the exacerbation in terms of the care that they could have received and may not have been comfortable going to receive either in person or via telemedicine. So, more work to be done certainly to make sure that as this stretches on, that we keep doing very consistent outreach, that we get creative about messaging. But we are really asking our providers to also do more outreach proactively to their patients, because they may not bring the issues or concerns that are emerging forward as quickly as would be useful.
Thank you. I think that we're heading to the end and I want to wrap up. I think what I'm hearing is it's clear that telehealth is here to stay, that it's an incredibly valuable tool. I think, Karen, where you just took us is painfully important, which is the pandemic is causing stress for all of us, no matter where we are in the income scale, no matter what race we are. But we know that the kids and families, low-income African-American and Latinx families in DC are suffering even more, and that it is really a crisis. And telehealth is a piece of that. And I am confident that we are all going to work together, Healthcare Finance, AmeriHealth, and Children's Law Center. I want to invite our audience to participate as well. I wouldn't be a good executive director if I didn't say one of the best ways you can participate is by supporting us financially. Or if you're a pro bono lawyer, you can take a pro bono case. We have lots and lots of opportunities for lawyers to directly represent children and families on issues that affect health. You can check out those mental health resources that Sharra mentioned on our website. And I think that this is one of those areas that takes both the vision, the caring, and the commitment with that kind of minute technical skill set, which Children's Law Center is proud we have, and it is clearly needed to navigate the complexities of Medicaid, but that we all need to keep our eye on the why, on why are we doing this, and how important it is for all of us to come through to the other end of the pandemic as a unified community with all of our residents able to grow and thrive and be part of our success. I know some of our panelists have to run because we're in the middle of a budget vote for the government, but also that a few of you can stay on and we'd be happy to take additional questions. So I am going to say thank you to our audience. And if you need to go, please do, but that we're going to continue to take questions for just a couple of extra minutes. Thank you, Melisa, Karen, and Sharra for sharing your expertise and your passion with us. And I just got a question, which is a funny one, so I'm going to share. In a moment of unusual candor, a hospital executive once told me that telehealth isn't attractive to them because they can't bill for it, or at the very least, not to the degree they wish. They make money when people come to the emergency room, when people come for a physical visit, even when they acknowledge it isn't necessary. How do we overcome those misaligned incentives? And I think, Melisa, you probably have a lot to say about that.
Well, I think, that just speaks to, the way we've approached it as a modality instead of a separate and distinct service. So if it's the kind of service that you would go see, on an outpatient basis, and it's something that can be performed in the home, Medicaid's paying the same rate one way or the other. So for us, that doesn't, that there's no delineation in the payment rates. That's not true across all Medicaid programs and so forth. So you might hear it. I don't know off the top of my head how Virginia and Maryland reimburse. So you may hear different things, but here in the district, it's reimbursement based on the service that you provide, whether it be in the office or via, telehealth or telemedicine subcapacity. So hopefully that will allay some of those issues.
Karen, I know you must think about this since you have an incentive to get kids healthy.
Yeah, so one approach to better align our practice behaviors with value and health outcomes is to look at alternative payment models such as value-based care. So we tend to approach those relationships by looking at the 3 pay-for-performance measures that the district holds the Medicaid managed care organizations to. And they're ones where we spend inordinate amount of dollars when those services are unnecessarily used, right? And so imagine how we could reinvest those dollars in our delivery system if we were able to get the appropriate reduction. So it's looking at all-cause 30-day readmission, right? That means the person was in for a stay, and then before 30 days even passes, they are readmitted. What could we do as a managed care organization to better support them? What could we do in terms of addressing the social risk factors? What could the provider do clinically to help them to remain stable? The second one is low acuity, non-emergency emergency room visits. So that's the person or their child going to the emergency room for sniffles because they just weren't sure what else to do. And, you know, I've been taking deeper and deeper dives on the data. And one of the things we find is that first-time moms tend to take their children, their newborns, to the emergency room more often. And that doesn't make them a bad mom. It means we've got to figure out how else to support them. And then the third category is potentially preventable admissions. So again, this is an admission where the person comes to the hospital, often for our enrollees through the emergency room, and they get admitted because it's unclear. It's like difficult to kind of figure out what is going on. So they may get admitted. And so if we can work to align those incentives with our providers, like the arrangement we have with you, which is to say, if you can help us by providing what you do really well to our enrollees to address certain issues around asthma, the child is going to be less likely to have a potentially preventable admission, a low acuity emergency room admission, or an all-cause 30-day readmission, right? So that's a great way to align incentives. And then we don't usually just have our programs be one and done. We try to keep evaluating what else can be supportive of better health outcomes. And one of those things is adding process measures about sharing data around social risk factors. And that way we all have the same information about the whole person that we can leverage without frustrating them by asking them the same questions over and over again, and marrying the medical and the social data, help them to be more stable.
Great. Well, thank you. And somebody just threw a question into asking, is the transcript going to be available afterwards? So whoever that was should just email me or anybody on the Children's Law Center team. And yes, we actually do have a transcription, so we can probably provide that. Thank you, Karen and Melissa and Sharra, for joining us. And you guys have been amazing. And I think we're going to close out the webinar. You guys can stay on, but I think we're going to close completely. Thank you.
Thanks for having me.
Thank you.
Thanks, everyone.
Hey.
Bye.